Thank you. Very good afternoon. I think for saving some time, I'll just go a quick description of the slides. So this study is basically about the Ponsegromab, which is a monoclonal antibody inhibitor of growth differentiation factor 15, which is used in patients with cancer cachexia. So this study was presented at ESMO Congress 2024, Barcelona. With the conflicts of interest here and the study funded by Pfizer, these are the declaration. And moving ahead, the study was conducted with the introduction to the study is that most of the patients definitely have cachexia in our patients with cancer. So what is the actual implication of the pathogenesis is that the GDF15, that is a growth differentiator factor 15, which is a stress cytokine, which is mostly increased in these patients, and that binds to the GFRAL receptor in the hindbrain. So that can cause the cachexia. So what does Ponsegromab do is it binds to the GDF15 and thereby inhibits its binding to the GFRAL receptor, which is in the hindbrain, and that's where cachexia improves. This is a phase 1b study. So basically it is to see which level of Ponsegromab which can give us the best advantage. So it's to evaluate the efficacy and safety and tolerability of the Ponsegromab compared with the placebo in patients with cancer cachexia and elevated circulated GDF15 levels. The study design was it's a randomized double-blind multicentric study. It was randomized into 1:1 into 4 groups, and the 4 groups included Ponsegromab as 400 mg subcutaneous Q4 weekly, or 200 mg and 100 mg, and one of the group was the placebo group. So the study visits were the day 1 and then week 4, week 8, week 12. So the main endpoint was to check the body weight, and the other endpoints were the patient-related outcomes, the physical activity and gait, safety and tolerability, and lumbar skeletal muscle index. So with these statistical analysis, I'm not going into details of the way the statistical analysis is made, but let's go to the results. So if we see here, so out of the 281 enrolled, 187 were randomized, many had screening failures, and then each of the group were, as said, like 1:1 manner. So the patients were almost 45 to 50 in each of these group, and all the 100% of the patients in each group were treated. And there were some discontinued patients, and most of it was either because of progressive disease or adverse events or death or global deterioration of health. So out of which, in each group, you can see here at the week 12, almost 70 to 80% could be assessed at the week 12. And this is the actual study. So it is also possible that these patients were given an option of extending to up to 1 year. So that was an option. So, but here I think we have only week 12 study data with us. So these are the baseline characteristics which were all matched. So most of the median age was around 60 to about 60, so 66 to 73. The sex, that's the gender, was matched. Most of the patients had a performance status of 0 to 1, almost around 80%. The race, again, the white were more than the Asians. The BMI is most of them had a 19 to 20. And percentage weight loss in 6 months before screening was either categorized into 5 to less than 10% or more than 10%. And the BMI adjusted weight loss category. So this was something that they checked the weight loss in the last 6 months and the BMI on the day of inclusion into the study. So they were categorized into 4 categories, and 4 means the severe cachexia. And GDF15 levels was a mandatory, so most of them had a high GDF levels. So the median was almost more than 3,770. So, and the type of cancers that were included were mainly 3, that is the NSCLC, colorectal, and pancreatic. NSCLC was almost 40%, colorectal was almost 28 to 30%, pancreatic was between 25 to 30%. And most of them were stage 4, that's almost 70%, and almost 90% were actively receiving the systemic anti-cancer therapy. And there were also one more stratification was based on the platinum-based chemotherapy, because apparently there is a notion that the platinum-based chemotherapy can increase the GDF15, causing the cancer cachexia. So the results here, like we can see the table here, the figures. it definitely shows this is on treatment and this is treatment policy. That's basically about the censored result analysis. So on treatment is based on the censored and treatment policy is without censoring. So we can see here, this is the placebo, this is the 100, this is the 200 mg of Ponsegromab, this is the 400 mg. If we see here, there's definitely a statistical significant increase in the weight in all the three groups, but the 400 mg are actually much significant than the rest. So the change was almost 1.33 kgs in the 100, 2.08 mg in the 200, and 3 kgs in the 400 mg group. So the body weight response was consistent again in all of these groups when compared to placebo. And this response was also seen at 8 weeks itself. Now coming to the 5% gain. So in comparison to the 100 and 200 mg, the 5% weight gain was more significantly seen in the 400 mg group. So the green is the 400, followed by the 200 and followed by 100. So this again tells us that it was consistent against all the subgroups, be it the cancer type or the level of GDF15. So there's the magnitude of GDF15, does it give a response, is something to be reassessed and reanalyzed, which was not the conclusion of the study. So, but in all the subgroups, be it the platinum-based therapy and the BMI adjusted, even in the severe cachexia group, that is BMI adjusted weight loss category of 4, and irrespective of the systemic inflammation, it all favored the Ponsegromab use in these patients with cancer cachexia. So that's what the result says. So the benefits at 400 mg dose was consistent across multiple domains. And these were the secondary endpoints, that is obviously the patient-related outcomes. Just to explain this, this is the number of patients. This is the number of patients who had shown the response. So definitely the secondary endpoints also had shown definite benefit. And coming to the safety was that a similar percentage of patients reported all treatment-related emergence effects. Only thing is that patients who were in the more placebo group had experienced more diarrhea than the patients who were on the Ponsegromab group. Otherwise, there were no new safety emergent treatment-related adverse events, and no deaths were considered treatment event. So this is same conclusion of the adverse events, and limitations of this study were few. So one thing is that in the second endpoint that they looked for the physical activation, they were basically using the digital devices, but actually those digital devices were not available to every patient at each time. So that was something that is limitation. The physical activity and gait endpoints were difficult to assess at all time, and there was a lack of racial diversity, and the study size and duration may not be sufficient to evaluate the impact on survival, and statistically there was no adjustment for multiplicity in the statistical analysis. To conclude, so I think it definitely going to be a future probably for our patients. So that is Ponsegromab improved the body weight, appetite and cachexia symptoms, and also the overall physical activity and skeletal muscle mass compared with placebo in patients with cancer cachexia and elevated GDF15 levels. That was mandatory for the result. So the safety profile was good, similar to placebo, and it is consistent that higher number of systemic cancer therapies would definitely have a little more side effects. And so this study supports the use of Ponsegromab in GDF15 high levels, and also implicates that GDF15 high is a driver for cachexia. Thank you everyone.